Today's topic by Dr. Stephen Gottschalk is titled Engineered Cell Therapy for Pediatric Solid Tumors. So really important topic. And you're in for a treat because Dr. Gottschalk is doing really important work in this area. He is the chair of the Department of Bone Marrow Transplantation and Cellular Therapy at St. Jude Children's Research Hospital. I personally have never heard of it, but I'm sure they do good work. I'm kidding, of course. He is a physician scientist who is interested in hematopoietic cell transplantation and cancer immunotherapy. Clearly, his current research focuses on the development of cell-based immunotherapies for pediatric cancers. He is actively conducting investigator-initiated early phase clinical studies. Thank you for that, with conventional and genetically modified immune cells. In the lab, his team of researchers is focused on overcoming current limitations of cell-based immunotherapies for cancer. For his contributions to the field of cell therapy, he was inducted into the American Society of Clinical Investigation in 2015. Well, I guess very belated congratulations on that decade-old award. Also really proud to call him an ALSF awardee many, many times over. He was commenting before we got on that it's been more than a decade that Alex has been supporting his work. He's had multiple innovation awards and also at least 4 trainees through our Young Investigator program that he has mentored. And this is a fun fact because when I asked him something interesting or something, he loves, he said, he loves what he does, and he really loves training the next generation of researchers. So love to hear that and really appreciate that you value that because we do as well. So I'm going to turn it over to you, and I'm going to leave from the screen, and please ask your questions as they come up, and they will get answered either during the talk at some point afterwards.
Thank you, Liz, for this very kind introduction. And just to make sure, does everyone see the full screen?
Yes.
All right. Thank you so much. So yeah, thank you, Liz, for the introduction, and really also thank you, your foundation, for everything you have done and are doing to advance cures for pediatric patients afflicted with cancer. So I will want to talk today about engineered cell therapy for pediatric solid tumor. And these are just my disclosure, which really do not affect, I believe, what I will present. And roughly, I want to give you a background, then really talk a little bit about CAR-T's, the clinical experience, then what we have set up in St. Jude over the last 5 years since I joined, and then talk about a few specific projects, and then close out in the end with some general remarks about some of the translation roadblocks we are facing in evaluating early or novel cell products, in particular in the pediatric populations. So just to put everyone on the same page, engineering T cells on a slide looks very easy. You take blood from patients, then in the laboratory, you can activate them. Then you use your gene modification of choice, either non-viral or viral-based gene delivery or gene editing, and then you add cytokines, and then, within a week or even now shorter, you have enough cells for preclinical as well as clinical studies. And, I think conceptually, you can think about really different classes of modifying your cells. Probably the most commonly used right now in the clinic is that you endow specificity by introducing a chimeric antigen receptor or, different versions of a synthetic T cell receptor. Then you can introduce modification to improve the T cell effector function. And lastly, not but least, you can engineer safety switches or other switches to, change levels of gene expression on demand, so to speak. And I probably would not be talking to you today would have been not of the advent of the chimeric antigen receptor, which was now firstly designed more than 30 years ago by a group around Zelig Eshar and Tom Brocker. And it really combines both of our immune system, where the specificity is derived from the humoral side, from a monoclonal antibody, whereas the signaling moiety are derived from the T-cell receptor complex. And it's very important to understand that there are significant differences what type of antigens CARs recognize versus alpha-beta TCRs. And in general, and I know there are specifically in pediatrics also no exceptions where intercellular proteins can be targeted with CAR T cells, but in general, a cell surface antigen is targeted. And that has significant advantages for diseases which are rare, like pediatric cancer, because the cancer only has to express antigen and does not have to express a certain HLA molecule. However, the cell surface approach limits us because on the cell surface, only a small percentage of proteins are expressed, and the vast majority of our proteins, and a lot of proteins which are mutated, so-called driver mutations, also in pediatric cancers, are not presented on the cell surface. So if you look in the literature on a bird's eye view, if you look in the solid tumor space, we also really have worked or have explored CAR T cells for pediatric cancer for the last 20 years. And incidentally, the first pediatric patients who ever received GD2 CAR T cell was in December of 2004 at Baylor College of Medicine. So it's 20th anniversary. However, if you compare the outcome of these studies to CD19 CAR T cells, which received FDA approval in 2017 for pediatric ALL, the outcome has been not so encouraging. Clearly, there's safety. Clearly, subsets of patients have a benefit. A recent study from Franco Locatelli's group in Rome really has highlighted that GD2 CAR T cells in the low disease burden setting have improved activity with excellent long-term survival. And then the group at Baylor College of Medicine also has now explored second genetic modification to improve GD2 CAR T cells for pediatric patients with DIPG. And more recently, Andras Hexy's group has highlighted the benefit of transgenic expression of IL-15 in glypican-3 CAR T cells for hepatoblastoma. I would like to highlight some of the results using our clinical experience using HER2 CAR T cells. And that is a project which I actually started when I first became faculty more than 20 years ago. And initially, we used HER2 CAR T cells without lymphodepleting chemotherapy in patients with sarcoma and brain tumors, and we definitely saw some activity. We saw pseudoprogression as a sign that CAR T cells can enter brain tumor and cause edema, and there was clearly transient anti-tumor activity. And these studies, were conducted together with Nabila Ahmed and Mina Hector at Baylor, and then also two junior faculty, Shobha Navai and Chris Dorenza, were involved. After having established initially safety of giving HER2 CAR T cells without lymphodepleting chemotherapy, we recently published our experience combining lymphodepleting chemotherapy with HER2 CAR T cells. And we initially only gave fludarabine, and then after establishing safety, we used a standard Cytoxan fludarabine-based lymphodepletion chemotherapy. And what you can see here is that we saw a significant increase in HER2 CAR T cells after lymphodepleting chemotherapy, which declined over time. And when we compared the AUC, the area under the curve of HER2 CAR T cells versus historical controls which did not receive lymphodepleting chemotherapy, depending on the cohort evaluated, there was a significant increase in the area or drug in the CAR T cell exposure of these patients. If you look at clinical activity in this patient cohort, there were 2 patients who received long-lasting CRs. 1 patient recurred, then was re-enrolled, and now remains in a very deep CR with a follow-up of more than 4 years. Depending on the used lymphodepleting chemotherapy and the cell dose, we saw some cytokine release syndrome, which is an expected complication of CAR T cells. This highlights a patient, one of the patients who had a CR, and it was a patient with recurrent refractory rhabdomyosarcoma who had desmond-positive, myogen-positive cells in the marrow. This patient received 3 cycles of lymphodepleting chemotherapy and HER2 CAR T-cell infusion, and each time you can see an increase, decrease, increase, decrease, and he had a complete response by morphological examination as well as imaging studies. Interestingly, this particular patient also activated humoral immune responses, antibody responses against his tumor, and we believe that was part of the reason why this patient achieved a complete CR. If you look at the overall outcome of this patient cohort, the 1-year overall survival rate was around 46%, and long-term survival rate was more than 5 years, 20%. This is, of course, different than for ALL, where the overall outcome is 50%, roughly looking at the early CD19 CAR T-cell therapy study. But this is done in a cohort where in the end, all patients are expected to die within a year. So we believe, although the numbers are small, that HER2 CAR T-cells, in particular in combination with lymphodepleting chemotherapy, had a clinical benefit on the study. Mina spent a lot of time looking at predictors of CAR T-cell activity, analyzing CAR T products, and she looked at known exhaustion markers. And while there was an increase in patients who had stable disease or progressive disease versus CR patient, due to the small patient number, this did not reach statistical significance. She also looked very carefully in pre-treatment biopsies in the tumor microenvironment using the genomics digital spatial profiling platform. And she looked in areas where there are viable tumors with immune cell infiltrate and in areas of the tumor where it's viable and necrotic areas. And if you focus on patients who had progressive disease, which are located here, interestingly, patients who had progressed disease had a higher number of NK cells in their tumors, a higher expression of CD68, which is an inflammatory marker, if myeloid cells are present, and less expression of granzyme B. And if you looked in the other tumor areas, again, here now the progressive disease patients are smattered here. There seems to be fewer helper CD4 cells and less granzyme B expression. So that, I think, gives us some hint that clearly the microenvironment of these tumors might predict, anti-CAR T-cell responses, and clearly future studies are needed to further, sustain or investigate and substantiate this finding. I now want to move on to the B7-H3 CAR program we started here at St. Jude. First of all, B7-H3 is an immune checkpoint, which was discovered more than actually 20 years ago by Naikon Chang's group at Memorial Sloan Kettering as a pan-cancer antigen for pediatric solid tumors. He at this time did not he generated an antibody, but he didn't know what the antibody recognized it. Later it was identified to be B7H3. Subsequently, there have been a lot of interest in targeting B7H3 with monoclonal antibodies, and including more recently also CAR T-cell studies. There have been case reports from China, and then the Seattle group has published their initial clinical experience using B7H3 as a target for patients with diffuse DIPGs, and more recently also published in JCO their clinical experience with targeting recurrent refractory solid tumors. We really got interested in targeting B7H3. That is now work by Chris Lorenzo and Dietrich Quentschut, who are faculty at St. Jude, because we carefully analyzed orthotopic brain tumor model as well as primary solid tumor samples at St. Jude. And this heat map is flow cytometric data. And if you look across now primary medulloblastoma, ATR, high-grade glioma, DIPG samples from pediatric tumor patients, first of all, there's heterogeneous antigen expression, but the top two consistently expressed genes are B7H3 and GD2. This heat map incidentally also highlights that it's critical that we study primary pediatric solid tumor patients or patient-derived xenograft model, because if you look at cell lines, they express all antigens. And for us to really pick antigens for evaluation in clinical studies, it is critical to really move beyond commercially available cell line and study pediatric samples. Again, also looking now at primary solid tumor samples, looking at an H-score for B7H3 expression. Clearly, there are across different histologies, including neuroblastoma, osteosarcoma, rhabdomyosarcoma. We saw significant expression of B7H3. In our initial study, we did not find significant expression Ewing sarcomas. Others have reported that. And subsequently, looking in a larger data set or larger sample set, we also found expression of B7H3s in subset of Ewing sarcoma. If you look at normal tissue, not surprisingly, we found some expression in adrenal glands, but with all our preclinical studies, we really never observed toxicity in normal tissues, including the adrenal gland in our IND-enabling studies. Chris Lorenzo's group spent quite a lot of time on evaluating the best CAR design. And initially, he evaluated different transmembrane domains and co-stimulatory domains. And after the initial screen, the best CAR T-cell population expressed the CAR with the CD28 alpha transmembrane domain and the CD28 co-stimulatory domain. And then we really also wanted to provide a 4-1BB signal and investigated two approaches. In one, we incorporated the signaling domain directly in the CAR. And in the other, we overexpressed 4-1BB ligand on the cell surface so that 4-1BB co-stimulation could be provided after initial CAR T-cell activation, which results in an upregulation on 4-1BB on the cell surface. And when he did a direct comparison, this product outperformed this product, and therefore we selected this product for our clinical studies. We've developed two clinical studies. One is led by Becky Epperly, and our brain tumor study is led by Kelsey Bertrand, and some correlative studies are led by Dietrich Quentschut. And on our solid tumor study, we use lymphodepleting chemotherapy. The patients get one CAR T-cell infusion, and then they're followed standard as in other study. However, we obtain a biopsy 2 weeks after CAR T-cell infusion to study the tumor microenvironment. And on our brain tumor study, patients get intracranial through Ommaya reservoir repeat infusions of CAR T cells, and there is a intrapatient dose escalation where patients get one dose level if they're safe. The second round, they get a dose which is threefold higher. And this study has two cohorts, one for supratentorial tumors and one for brainstem gliomas. And the main reason for having two cohorts is that based on the clinical experience by other investigators, we felt that there is probably a safety difference, whereas you have much more space when it comes to tumor cell swelling after CAR T-cell administration for supratentorial tumors. If you are in the brain stem, there is much less wiggle room, so to speak, and therefore we stratified these patients according to their disease location. This is a snapshot of the ongoing clinical study. Our current experience is on the IV side, that B7-H3 CAR T cells are safe. On the dose levels evaluated so far, there's limited expansion. However, there's clear evidence of homing to tumor sites and anti-tumor activity. And this shows one metastatic lymph node, which was biopsied 3 weeks after CAR T cell therapy. And there's a huge area of necrotic tumor with adjacent viable tumor mass. On the brain tumor side, again, overall it was safe. A lot of our patients had fever and headaches within 24 hours after receiving CAR T cells, and some also developed clinical signs of increased intracranial pressure requiring drainage of CSF fluid. And we detected very high levels of CAR T cells, which declined over a week. And again, there was definitely evidence of anti-tumor activity. That is one of the DIPG patients who over 6 weeks had a significant decline in the tumor area, which since then has continued. You know, we set up this initial study really to then have it as a platform to develop subsequent studies where we now also introduced genetic modification to further enhance the activity of B7-H3 CAR T cells. And the reason is really driven by this fact. You know, everyone who works in the CAR T or alpha beta TCR T cell field can do a similar experiments in vitro where you recursively stimulate the antigen-specific T cells with tumor. And what invariably happens is that after an initial expansion of our tumor-specific T cells, there is progressive contraction. And in the end, the cells die out. This phenomenon is called in part T cell exhaustion, but those who are in the field, or particularly in the T cell immunology field, are aware that exhaustion is a very controversial term because we really do not have very clear definition. And most importantly, it is ill-defined at what stage T cell exhaustion is really irreversible. And we all want to be in a state like this, where we can continue to give or expose our T cells to tumors and they continue to proliferate in a tumor antigen-specific manner. Conceptually, groups have approached this dilemma by two approaches. One is by deleting negative regulators in CAR T cells, which limit T cell activation, epigenetic regulators, or deleting transcription factors, which are associated with limited CAR T cell function. And the other strategy is really transgenic expression of cytokines, which stimulate T cells, chimeric cytokine receptors, or also transcription factors. And we are really, so to speak, almost in a dilemma that it's very, very difficult to decide which of these strategies now to select for clinical evaluation. And it can almost lead to paralysis because there are so many options to choose. So we decided to focus on Recnase-1 knockout CAR T cells as our next B7-H3 CAR T cell product, which we want to develop. Recnase-1 came out of one of the first limited screens, in vivo screens in animal models as a negative regulators of CAR T cell function. The screen was done by Hongbu Chi at St. Jude. And if you look at the volcano plot, Recnase-1 is really, there's no question, there's at this particular screen, deleting Recnase-1 gave the biggest advantage. And while the initial studies were done in OT1 transgenic mice, he then together with also Terry Geiger confirmed this finding in female TCR T cells as well as CD19 CAR T cells. Reassuring to us, other groups have also reported that Recnase-1 knockout improves the effector function of CAR T cells as well as TCR T cells. We now wanted to ask specifically, does Recnase-1 improve B7-H3 CAR T cells in murine and human tumor model? And then we really wanted to take advantage of our immune competent animal model to ask the question, does Recnase-1 knockout manipulate or influence the tumor microenvironment? Because in the end, not only myself, but others in the field believe that we really have to change the tumor microenvironment to get long-lasting effects for if we want to use CAR T cells as a biotherapeutic for pediatric solid tumors. B7-H3 is broadly expressed in pediatric brain tumors and solid tumors. Our initial clinical experience highlights that targeting B7-H3 is safe. And based on the data presented, we decided to move Recnase-1 knockout forward as our top candidate for clinical testing. We are currently in the process of procuring the clinical grade guide to do clinic GMP grade knockout of B7-H3 CAR T cells. And it will take us, I estimate 12 to 15 months before we can open this particular clinical study. So in the next part of my talk, I now want to focus on antigen discovery. What are other potential targets for pediatric cancer? And that is the recently published project we did together with Jingwei Zhang, who is in the computational biology department at St. Jude. And what we wanted to do is not only look at differentially expressed genes. So, a lot of gene expression studies had focused on this setting where you look in normal tissue and then you look in tumor tissue and you look for differentially expressed genes. But we knew from the literature that splicing is defective or altered in a lot of cancer. So we really also wanted to ask the question, are there differentially expressed exons between normal and tumor tissue? And to do this analysis, we took advantage of a large pediatric data set. We used the PCGP data set, the target data set, and then we used the ClinGen data set of St. Jude and analyzed, I would say, a huge data set, at least for pediatric cancer, which consisted of almost 1,500 pediatric solid tumors and brain tumors. And we developed a computational pipeline called CSE Miner, which is publicly available on the St. Jude cloud, and was really spearheaded by a very talented postdoc, Tim Shaw, who now is faculty at Moffitt. And based on the developed pipeline, we discovered or identified 9 targets which are differentially expressed or alternately spliced exons, and 148 genes which are discovered on which are overexpressed on a gene level. And we, in the end, classified these genes as tier 1 versus tier 2. This had to do with some background expression in normal tissues. And kind of as a sanity test, if you look at a lot of the targets on the gene level we discovered are targets which are in the clinic. Glypican-2 for neuroblastoma, glypican-3 for rhabdomyosarcoma and Wilms tumor, B7H3 CAR, as already mentioned, and then also some melanoma-specific cells targets. What really got our interest was that a lot of genes which are expressed in the extracellular matrix were either overexpressed on the gene level or had differentially expressed exons. And we, in the end, have published the COL11A1, the fibronectin, and very recently our data on targeting tennessine C. And another gene which really caught our interest was LRC15 for osteosarcoma. If you look here, it is really highly expressed in osteosarcoma, and this is very clean if you look here at normal tissues. LRC15, again, we are not the first to explore that as a target for immunotherapy or targeted antibody drug delivery. AbbVie had a compound which was evaluated in preclinical studies and then also in the first-in-human studies in 34 patients. And actually, some of these patients had osteosarcoma, and there was one really dramatic response and smattered responses throughout. And if you look at spider plots, some of the responses were actually quite long lasting, 6 months and longer. However, unfortunately, AbbVie decided not to develop that ADC forward, and that compound is no longer available for early phase clinical testing, also in the pediatric population. So Chris Dorenzo decided to make a CAR and also, first of all, compare with our validate with our pathologists, Celine Koo and Heather Shepard, LRC15 expression in osteosarcoma. And clearly, there are tumors which express it at a relatively high level, and then there are tumors which express it at a relatively low level. And he designed, 4 constructs, and there was quite nice anti-tumor activity in vitro and also in our standard in vivo models. He then used one of Jason Houstein's cell lines to ask in our immune competent model, and this particular cell line F420 does not overexpress LRC15, so he engineered it to express LRC15. And there was, again, a very nice anti-tumor activity of this unmodified CAR T cell in the immune competent model. And he also performed extensive safety studies and really did not observe any significant anti-tumor activity. Of interest, LRC15 is expressed primarily in hair follicles. That was well known from the AbbVie study, but we really did not observe any alopecia in our mice. And we are very, very interested in really moving LRC15 also forward as a CAR T cell therapy target for osteosarcoma. In the last few minutes of my talk, I now want to touch on chimeric cytokine receptors as a genetic engineering approach to enhance anti-tumor activity of CAR T cells and close with some thoughts on how we can hopefully enhance our ability to test these approaches in the clinic. As most of you know, T cells require a set of signals so that they function properly. In general, everyone knows about signal 1, which is activation, co-stimulation, cytokine signaling. But more recently, there's also really lots of data that T cells also require the right metabolism signals to function properly. And this is, in general, has now been accepted to call it the signal 4 of T cell activation. Lots of groups are using engineering approaches to enhance cytokine signaling, including the systemic administration of cytokines, or genetically engineering approaches so that T cells secrete cytokines. I would say there are some toxicity concerns, but as already mentioned in the beginning of my talk, these approaches are being explored in early phase clinical studies. And for example, under a study where IL-15 is expressed in glypican-3 CAR T cells resulted in very encouraging activity in pediatric solid tumors who express glypican-3. We really felt that we really wanted to look at chimeric cytokine receptors, which limits the engineered cytokine signals only to genetically modified T cells. In the literature, there are, if you just think about cytokine signaling, there are lots of choices. Which cytokine signaling pathways should we activate? In general, there are common gamma cytokine receptor pathways which activate STAT5, STAT3, or STAT6. And then, there are other STAT molecules. And then there is a MyD88 signaling pathway, which is activated by toll-like receptors, but also by IL-18 or IL-36 gamma. And now groups have played with, activating certain signaling pathways, which in the end is then very difficult to perform comprehensive comparison. And therefore, when we started to work on that, we really wanted to come up with a modular design so that we can compare cytokine signaling pathways in preclinical models to then come up with the best molecule for clinical evaluation. And this was work done by a former graduate student of mine, Matt Bell, in combination with the structural biology department at St. Jude. And we replaced the extracellular domain of cytokine receptors with leucine zippers. And based on the modeling, we made receptors which have either 1 or 2 leucine zippers. The 2 leucine zipper approach allows you that now not only heterodimers, but higher molecular structures are being formed because these leucine zippers can pair in a parallel and anti-parallel fashion. We first confirmed that indeed within cells, there is a higher area labeled with fluorescent probes if you use a 2-zipper approach. And then more importantly, if you look at STAT5 activation within T cells after transduction, only T cells which express both zip receptors which had 2 leucine zippers had a significant increase in phospho-STAT5 versus the one which only had 1 zipper. These zippers now allow T cells to survive in the absence of cytokines, which is shown here. If you take non-transduced T cells and do not feed them with cytokines for a week, they are all dead. However, they're in the presence or having them genetically modified with these zip receptors, they are alive. And this is linked to the JAK-STAT activity, because if you do the same experiment in the presence of ruxolitinib, which blocks this pathway, the benefit of expressing zip receptors is lost. One question, of course, which comes up right away, do you just create a cancer? So we developed a very stringent autonomous cell growth assays, where within 30 days, Jurkat cells outgrow. And we did not observe any outgrowths of T cells which were genetically modified with these ZIP receptors looking out to 60 days. Now you can ask yourself, why is that the case? Is it magic, or is there an explanation for it? And the explanation is shown in this flow plot. If you genetically modify T cells with a ZIP2 receptor, you just turn on the STAT-fast base a little bit. However, if you add cytokines, which improve or cause autonomous growth of T cells, you get this huge shift to the right, highlighting that while ZIP receptors activate these pathways, they only turn them on a little bit. And then, of course, the question was, does this little activation results in improved effector function? And the answer is yes. First, we showed that T cells which express ZIP receptors do not alter their specificity. Then we did repeat stimulation assays, and only T cells which express the ZIP receptor continue to expand after re-exposure to tumor cells. And that was strictly antigen dependent. So when you did the same experiment with a cell line where the target antigen was deleted, there was no outgrowth. And then we saw improved anti-tumor activity in multiple models, including subcutaneous Ewing sarcoma model. We looked very carefully what expression of the ZIP receptor does to the T cells in vivo, and there was a higher ratio of memory and effector-like cells. We observed, not surprisingly, increased STAT5 and STAT4, and also increased pathways which were associated with T cell activation. The system is now modular. We can activate STAT3 and STAT4, and depending on the STAT molecule, we can now see anti-tumor differences in anti-tumor activity. For example, in the STAT3 activating model, there is less of a benefit versus a STAT12. And lastly, not but least, more recently, we've also made IL-18 ZIP receptor, and that work was just published. And we now believe that we have a toolbox where we can really start comparing all these ZIP receptors and then decide which one we want to move to the clinic. So to summarize this part of the talk, as I mentioned, we have now, I think, a good toolbox, so to speak. Ongoing studies are highlighted on simplifying the design, a head-to-head comparison. We started to evaluate these in immune-competent model, and we are also starting to make now receptors where we can activate multiple pathways. So at last, I just want to highlight at least that some of the issues we've, at least as I see it, we have experience in moving these things to the clinic. Doing clinical studies in the cell therapy space was always a big task. This shows a slide from 2007. To my embarrassment, in that time, we used Blue Font and Comic Sans as our, form, but it was always complicated. But, in 2007, if you just look, there were 49 preclinical publications on CAR T cells in PubMed, and now there are more than 2,000. And then this really raises this question, how to prioritize clinical testing and how to accelerate clinical translation. And we really have to start to work with the regulators, which will, so that we can actually evaluate multiple cell products with different genetic modification in a single study, because we will not be able to do it one by one. We will be just far too slow, and it will be also, in the end, cost prohibitive. So with that, I would like to close and say that, I've not talked about CAR T cells for pediatric ALL. It's a prime example that CAR T-cell therapy can work for pediatric cancer. And for solid tumors and brain tumors, there is, I think, lots of things to do. I think it's a prime example where we in academia can still have a huge impact in better understanding the biology, discovering new target antigens, develop genetic engineering approaches, and also really work on evidence-based combinatorial therapies to really improve these therapies. And in the end, you have to thank a large team. I hope that I've highlighted everyone who contributed to the data I've shown. And with that, I thank you for your attention. I'm more than happy to take any questions.
Thank you so much. We have a question, and I think we have time for a couple questions. So if there's another one, put it in the Q&A. In your syngeneic murine osteosarcoma model, are you using lymphodepleting chemo prior to CAR T infusion?
That's
Hopefully
a
I
great
got that
question.
right.
Yes. So right now we have decided, at least in the initial studies, not to do it because we were very interested in studying the direct effect of the CAR T cells on the tumor microenvironment. And we were worried that cytoxin might be a huge confounding factor. So we have not done it, but we are now planning the studies mainly to gather additional safety data for, as we start working to put the IND together.
Okay. I had a question for you. Right at the end there, you mentioned accelerating clinical translation. And I think you said you need to work with regulators. Can you explain that a little bit more? And then we do have another question that just came in.
Well, I think, we all who do these studies work with, with CBER very closely together, trying to, for example, come up with where you almost have, so to speak, a parent IND, and then could submit other INDs to it or other studies where you evaluate related, slightly modified product, for example. And that should, in the end, take some of the regulatory burden, away and make it easier than having siloed, separate INDs for all these studies. So that is, one example. How to implement it, we're actually just trying to do that for some of our upcoming studies. We'll see, but I'm hopeful that that is one example where we can reduce some of the regulatory burden in moving these things forward.
That would be great if you can manage to get that done that way. Okay, two more questions. You mentioned anti-tumor ABS or ABS being generated downstream of CAR T. Any evidence of CD8 epitope spread? Sorry if I'm not saying that right.
Oh, yeah. So the question is about epitope spreading.
Yeah.
That really has not been, I think, observed, at least in clinical studies so much, but I believe that there is now some evidence. And the evidence comes in part out of looking in the TCR repertoire of non-genetically modified T cells of, after CD19 CAR T cell therapy. That's work done by Ulrike Gerdemann in Boston. And I believe her paper in Blood was published, a couple of months ago. So while by, ELISpot assay, etc., that has been not so much, at least to my knowledge, has not been observed on a lot of studies so far, looking at the TCR repertoire of the non-modified endogenous T cells. There is clearly reshaping going on, suggesting that CAR T cells are able to induce, antigen spreading or epitope spreading. But I believe, additional studies from other clinical studies are needed.
Okay, and then I think this will be all we have time for. One more question for the intraomya administration of CAR T cells, did you expect to see more ICANS or other toxicities as a result of the orthotopic administration?
So great question. And that is really, so what we observe is really not so much ICANS, but TIANS. That is the new classification system put together by, the Stanford group, because, while ICANS is a generalized inflammatory process in the brain, TIANS is more local inflammation. So yes, we have seen TIANS and also some higher grades. As I mentioned, we had to drain CSF from the Ommaya reservoir to release increased pressure. So, but I think from a physiological perspective, I think it's very, very different because it's due to swelling at the tumor site, whereas ICANS is really caused by a general inflammatory process. So at least for us, doing TIANS grading instead of ICANS grading for patients who received intracranially CAR T cells has been very, very helpful in assessing side effects, but then also using approaches to mitigate these.
Okay, thank you very much. There was an additional question. I don't know if it's a 1-minute question, but I'll read it to you. Do you see any lymph node involvement in the murine model for CD8 cell or any memory studies? Do you do radiation before CAR T?
We don't do radiation. We have not looked carefully at draining lymph nodes in these experiments.